Live streaming is on.
I remember when I lost my mind. There was something so pleasant about that place. Even your emotions have an echo in so much space. And when you're out there without care, yeah, I was out of touch. But it wasn't because I didn't know enough. I just knew too much. Does that make me crazy? Does that make me crazy? Does that make me crazy? Possibly. And I hope that you will have the time of your life. But think twice. That's my only advice. Come on now, who do you think you are? Bless your soul. You really think you're in control? Well, I think you're crazy. I think you're crazy. I think you're crazy, just like you. My hero has a heart to the life I want to live. And all I remember is thinking I want to be like them. Ever since I was little, it looked like fun. And there's no coincidence I've come. And I can die when I'm done. But maybe I'm crazy. Maybe you're crazy. Maybe we're crazy. Probably. Desconocida, que deje huella, que aviente mi maldad, que deje bestias, que ponga en su lugar pura inocencia, que te cubre tu cuerpo sin darte cuenta, que hables sin pensar las consecuencias, que digas tu verdad aunque llueva piedra.
Mira, un Mercedes eléctrico. No, es gasolina eléctrico. Gasolina eléctrica.
Like the legend of the Phoenix, all ends with beginnings. What keeps the planet spinning It wasn't the beginning. Look, we've come too far to give up who we are. So let's raise the bar and it goes to the stars. She's up all night to the sun. I'm up all night to get some. She's up all night for good fun. I'm up all night to get lucky. We're up all night to the sun. We're up all night to get some. We're up all night for good fun. We're up all night to get lucky. 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 The present has no limit. Your gift keeps on giving. What is this I'm feeling? If you wanna leave, I'm with it. We've come too far to give up who we are. So let's raise the bar and it goes to the stars. She's up all night to the sun. I'm up all night to get some. She's up all night for good fun. I'm up all night to get lucky. We're up all night to the sun. We're up all night to get some. We're up all night for good fun. We're up all night to get lucky. 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 She's up.
Go.
Sì. Hi everybody, we are waiting some minutes more for permit the people to connect.
Hi everybody.
In the meanwhile, I just want to say that I'm really glad and grateful to be here as a moderator. I want to thank all the Periresto group that since the last time that we have met, they have done a great job, a really great job. I want to thank on the behalf of the group for the 10,000 followers just reached. And with great pride, we can say that Periresto is now the largest online dental training platform for free. Every time is a great experience for me, as the level of the relation and the speaker is always very high. And today is no less. For me, it's a great honor to introduce you, Edoardo. Dr. Fossati, Edoardo, that I met in person, is a great clinician. He graduated from dental school of the University of Turin, and he have done some master degree in oral medicine and dental care, and a postgraduate degree in reconstructive surgery of periodontal and peri-implant tissue. Most of all, he is a tutor for private courses in restorative and aesthetic dentistry with Dr. Riccardo Becciani, that I really want to greet personally. He is also a tutor for private courses in endodontics with Dr. Enrico Cassai and active members of Think Adhesive. He's a speaker in national conference. He published on national, international journal, so a lot of things. I strongly advise you to stay connected until the end, because the cases presented today are very didactic, full of tips and tricks, and most of all, interesting mistakes. So also because probably soon Dr. Fossati will realize how good he is, and he will start charging for his courses. So let's start. For any question, please write below on both channels, Instagram or YouTube. And at the end, we will report to Edoardo to the question answer at the end. So, Edoardo.
Thank you very much, Fede. If you want, I can start, and it's an honor for me, and I'm very glad to per il resto. So, if you want, I can start. Share my screen and start. Okay. Okay. Wait a minute, and. Okay.
Take your time, Edoardo, because we are waiting that some people more can enter. They are writing to me.
Okay. When do you want to? Then when you want the start, I can start.
Okay. Okay. I think you can start. We can start and we can go on.
Okay. So. Okay. Hello, everybody. Like I said, I'm very, very glad for your invitation. So thank you guys per il resto. And I don't want to lose my time and waste my time in presentation. So I start the lecture right now. Tonight, I want to share with you the backstage of complex in my end, adhesive rehabilitation, and move on through my mistakes to find some practical tips that maybe you could use tomorrow in your office. I don't like too much to make only a show in my lecture, but my desire is to make a sort of practical lecture that could be useful to everyone. And what do I mean with complex rehabilitative case? I mean cases that involve entire arches, one or two arches, in which we have to change the occlusion of the patients. In this case, in this type of cases, sometimes we have to change vertical dimension of occlusion and masticatory pattern. This is for me a very complex case. In my opinion, the difficulties of these cases are not only technical, but are related to management in terms of workflow, in terms of appointments, and in terms of time. So my aim in this lecture is to talk about workflow and protocols that we could use to restore in a standardized way complex cases. And like I said, in my lecture, I don't want to make only a show, but I want to share my problems, my mistakes, and my errors. So I really want to share with you the backstage of my daily practice. Okay, now if you want, we can start. The first cases that I selected is a case that had some topics that are in fashion now, like the flow injection technique and vertical dimension augmentation. In this case, we have Francesco, that was 71 years old. He came to my office with only one small problem, the sensitivity on the mandibular incisor, and because he didn't like the shape of this teeth. His expectation was to align mandibular incisor. So he wanted to align the edges of the mandibular incisor. No more. With this type of patient, I immediately thought that was a perfect case for TERI technique of flowable injection. And as always with this type of technique, I've started with a request for my technician of very accurate and beautiful wax-up. But what did I mean with accurate and beautiful? I mean that the technician have to work well on the wax-up as if the wax-up was the base of the final ceramic restoration. I need a very remarkable shape and very remarkable micro and macro texture, superficial texture. So for the flow injection technique, for me, the first point that we have to remember is to ask a very accurate and beautiful wax-up to the technician. Now we talk about the technique, and as you know, to transfer the wax-up in the final restoration, we need a translucent silicone guide like this one. And before the stamping, obviously, we start with adhesive step. And generally today, I only use universal adhesive in self-etch technique with the etching of the enamel. I don't use the itch and rinse technique, but I prefer the universal self-etch technique. In this case, when I stamp entire buccal surface, I can't use the dental dam because with the dental dam, it is very hard to insert the silicone guide. So I only use the Teflon to isolate neighboring teeth. Some tips of this technique. First, the use of the 305 fiber. When I have to stamp the entire buccal surface of teeth to make a veneer, I prefer to use a fiber to have a better adaptation of the silicone guide and to see better the enamel. And another point is to isolate one by one the tooth if you're making first flow injection technique to get your attention only on one tooth. If you are an expert dentist, maybe you could isolate more than one tooth in alternate way. And I suggested you to isolate one by one because when I started with this type of technique, my expectation was for a very easy and super fast technique, but reality was very different. This was the reality. The reality was that often with this technique, we need much time to polish and finishing. So remember to take your time to polish and finish. And remember to choose a night translucent and dark material to see the composite during the injection. This is my favorite material, material of the Kulzer, Memosil 2. And here you can see another type of flow injection technique. Here I'm mounting the dental dam because I had to stamp only a part of buccal surface. This is the other side, and here you can see the final situation of after 1 week. But now I want to ask to you to make a rewind and come back to the starting situation. This was the starting situation, but this wasn't the real starting situation. Because here, a lot of tabletop. Why a lot of tabletops? Because I wanted to increase vertical dimension. Because this one was the real initial situation with a very, 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 very deep bite. So now we start again with this case. Every time that I see a patient with great losing of tooth substance, I try to understand the reason of the pathology situation. I feel that many of us, when see patient like this one, immediately thought to clenching. But are you sure that is always clenching? I think not. I think not, because we have to see the all data of the patient. This is all data of the patient. The patient, Francesco, 71 years old, has a lack of posterior teeth and has a very deep bite. Has erosion. You can see the erosion on the occlusal surface of the posterior teeth. The patient has low plaque index and cervical abrasion, and the patient had a Michigan splint. So, in my opinion, this was the history of the patient that caused the loss of vertical dimension. So the patient had a deep bite, then extraction of some posterior teeth in childhood, daily lemon intake. That was the reason of the erosion, and the patient has aggressive tooth brushing. So now, with this data, we can go on to the rehabilitation. In general, when I approach big rehabilitation like this one, with abrasion and erosion factors, and where I've lost the tooth substance, I start from the determination of the correct length of central maxillary incisor and with the determination of the exposure at the rest position. But in this case, no, because first, because the length of central maxillary incisor are kept, and then because the only real request of the patient was to align incisal edges of lower incisor. So we have to start to lower incisors. So for me, the first problem that I want to solve is understand how many millimeters I have to extend the mandibular incisor to reach a good aesthetic situation for me, overall for the patients. And I think that it was 1 millimeter, only 1 millimeter. Then I take 2 silicone impressions and a facial bow to place maxillary model on articulator. And as you know, for this case, we need a wax of centric relation to place the mandibular model in articulator. I need a centric relation because when I have to increase the vertical dimension, I lose dental occlusal contacts, so the intercuspal position are not useful anymore. So I insert a hard wax between the teeth of the patients. And in this case, I've decided that I want to increase the incisor length of 1 millimeter. So when I place the wax into the mouth of the patient, I've asked to him to close the mouth using the dorsal manipulation until the thickness of my wax was only 1 millimeter. And I use the caliper to measure the thickness out. Remember that the wax is stable only when it's cold. So we need an hard wax like Moico 1, and we have to put the wax hot into the mouth of the patient. Then we have to wait that the wax becomes cold. Then we have to put the wax into cool water and check another time into the mouth of the patient, because the wax has to be very, very, very cold to be stable.
I'm sorry, Edoardo, I just want to ask you one thing. We talk a lot about these things, okay, this stuff last day, and I was really interested about how do you take the wax, because you have to be really precise. Sometimes we take the wax just like this, superficial way. Instead, it's a really important step, I understand. And the centric relation with the dozen, okay, it's really important, I think. So how do you take the centric relation with the patient, in which position, and all this stuff?
Okay. Okay, it's very your question is very important. So this is the focus point of this type of rehabilitation. You have to put the patient in very relaxed position on the chair. So you have to take a Moico wax that yes, Moico wax that have to be very, very hot, because when the patient closes the mouth, the wax had to be very, very, very very hot and very not to be hard. So then you have to check with the dorsal manipulation the movement on the jaw, and then when the jaw is very relaxed, you have to move the jaw in the position that the jaw want, and it is the centric relation. Then when the jaw of the patient is very relaxed, you can check 2 or 3 times, and then you have to wait. Wait 30 seconds, and the wax became cold. So the wax is into the mouth of the patient, so the temperature of the wax is 37 degrees. So you have to remove the wax from the mouth of the patient and put the wax in a cold water. So you have to wait that the wax became cold. Then you have to take another time the wax and put the wax inside the mouth of the patient. And then with the same manipulation of Dawson, you can move the jaw and check the centric relation.
Okay, thank you very much.
Okay. Okay. Now we can move on the articulator. So we have to mount the models in articulator with the reference of the articulator at 0. And in this type of cases, I've always taken the impression with silicone to improve the precision of wax up. And in articulator, you can see the two cast models at the new vertical dimension of occlusion. In the anterior space will be the wax up for the anterior direct restoration. And in the posterior space, the wax up for the posterior tabletops. And as you can see here, there is the master lower model without any changes. And the upper one that is a duplicate of model with posterior wax up. So my technician have made the wax up on the maxillary model. Then my technician have duplicated the master model with the wax up to avoid to break the wax up. Now we go on the fourth step. So I translate my wax up to the mock-up with a silicone guide. And here you can see that the patient have the same vertical dimension with the caliber wax and the mock-up. And a summary over here is I've taken 1 hour with the patient for the first visit in my office. Then I've taken a second appointment. I always take this appointment to case study, and I've taken 1 hour and a half, and then 2 hours to stamp the mock-up. So if the mock-up is right, I stamp the mock-up into the mouth of the patient with the spot etching, and I wait about 15 days for 1 hour. For 2 hours, 30 or more days. Then, after 15 days, I remove the mock-up and I measure it out before my preparation. The mock-up on 2.7 measured 0.3 millimeter of thickness. And now I have to decide how that will be my preparation. Here I mainly have enamel on the posterior tooth. So I can use a very thin overlay because the overlay will be cemented on the enamel. And I've chosen to calibrate my preparation on 0.6 millimeter. Why have I calibrated my preparation in this depth? Because I knew that my technician on 0.3 millimeter can work very well, but it can work at the 0.6 millimeter. So now I have to calibrate my preparation, and to calibrate my preparation is very easy because I've taken a bar of 1.2 millimeters. So I've taken a bar and I calibrate and I measure out the bar with a caliber, and the bar was 1.2 millimeters. So I've inserted only a half bar on the tooth to create to make a guide, a occlusal guide, with the mock-up printed in the mouth of the patient. Then I move on the back side to make a light chamfer to camouflage my onlay. And then I go on to the cementation. And these are lithium disilicate overlays that, as the paper of Petra Guess has said, we know that this disilicate cementing on enamel dramatically increases its resistance. So lithium disilicate on enamel is very similar to the zirconia in resistance. And now we move on to the isolation of the field. And here you can see the cementation. I've worked without make proximal box because I had a need to open contact point. And I have cementing tabletops over the contact point. And when I have to cement the tabletop in adhesive way, I always use this high loaded flowable composite. And to increase the handling of this type of composite, I used to cool the flow in fridge before the cementation. So I put in fridge at the start of the appointment this type of composite. Liquid dam with this type of very thin only is very useful. And but today I prefer to use a flow composite like liquid dam, because the flow composite work well like a liquid damp, but I don't need to have another material. So I use the flow like a liquid damp. And
may I ask you, sorry, Edoardo.
Okay.
May I ask you just one thing?
Yes.
They report me one question. I want to ask you, which is the limit of the vertical increase? You talked about vertical increase before, so they want to know which is that limit for the vertical increase. You talk about 1 millimeter, and
yes.
For example, in patient with an exaggerated SP curve,
the patient that we have
with an exaggerated SP curve.
SP curve.
La curva di SPE.
Okay, yes. Okay. Okay. I think that in these cases, the problem that was I can work in the maxillary in the jaw, because in the mandible of the patient there were a lot of ceramic restoration that the patient wanted to maintain. So I only work on the maxillary maxillary arch. So I can change a lot the SP curve. Do you understand?
Okay. Yeah. Sure. Perfect.
Okay. So
thank you very much.
But in general, to my experience, you can increase the vertical dimension about 5 to 7 millimeter in only one step. So if I have to increase the vertical dimension of a lot of millimeters, I increase the vertical dimension with one step, so only with one mock-up. Then I try the mock-up, and if the mock-up break out, I change my plan. And in general, when I have when I can to work to 2 arches, like the next cases, I pay a lot of attention to the curve SPE and Wilson SPE, but not in this case, because in this case I can only work on the upper surface.
Okay, thank you very much.
Okay.
It's really clear for me. Yeah, thank you.
Okay. And this is the final situation. Here you can see for that question, you can see on the mandible in the third quadrant, you can see the old ceramic restoration. Okay, And here you can see the vertical dimension of occlusion with the wax, the same vertical dimension of occlusion with the mock-up, and the same with the final restoration. And here you can see the guide, the anterior guide. You can see the occlusal point of view, and you can see the lateral side. Here you can see the starting situation and the final situation of 1 year follow-up. Indeed, you can see the plaque. Okay, now I want to go on with a more complex, obviously in my end, case. That more complex because involves 2 arches and in which we've placed implant. This one was a patient that had a very advanced abrasive condition. And this one was the starting situation during my first visit. A few months later, the implants placement from my colleague. As you can see, there were a lot of issues to solve. Probably the first was the vertical dimension of occlusion. It's a case that I haven't done in my office, haven't done in my office, and during the first impressions that I've lost 2 implants. Obviously, the patient didn't want to place another implants, so I've been forced to change my treatment plan. And then after made a new treatment plan, I've working following the same step of previous case. So the first visit of 1 hour, the case studies of 1 hour and a half, and the mock-up of 2 hours, then 30 days. And as you remember, during the first visit, had better know the history of the patient that in this case started with maxillary 3rd class and the loss of some posterior teeth for caries. Then an increased anterior masticatory load with and then the patient has an aggressive to brushing during every day. And in the second appointment, we make the case study in which we take a good and accurate impression. I use the silicone, and in this case, I use the polyether. I have to take the facial bow, the centric relation, the pictures, and the length of central incisor. That is really important to determine the final dimension of the teeth. And now, before the 3rd appointment, we have to plan the case. And we start with the determination of central incisor length. With the technician, I always start making an ideal central incisor length. Remember the age of the patient, that in this case was 75. After determination of the position of incisor ledge, we can start to ask to the technician the wax-up. And the technician builds the wax-up according to the ideal aesthetics parameters and eventually personalize the shape. Then I translate the wax-up in mock-up and leave it into the mouth of the patient for 30 days. When we achieve a good mock-up for us, and especially for the patient, the difficult side of this type of rehabilitation is finished. So from here on out, it's easier. Okay, so it seemed very easy. But what was the reality? My reality of this case? My reality was being rich in problem. And now I'm going to share the real history of the patient, my real clinician history of the patient, my problems and my errors. So my first problem that I had was to place the maxillary incisor ledges. Why? Because this one was the starting situation without any reference. In this case, I've started only building two central incisors with an ideal length of 11 millimeters. So I asked to my technician to make two central incisors of 11 millimeters and then make the other teeth. And after making this teeth, I check out the exposure in the rest position. But now, in new cases, I prefer to make a fast and simple smile design on PowerPoint or on Keynote. So I take this picture and the picture of the face of the patient. I simply set the picture on the horizon plane. Then I use the measure of the central incisor, the real measure with probe of central incisor, and then use that measure to calibrate the digital ruler. Then I make a Keynote Smile design, and I only change the dimension and the shape of the same tooth, teeth. And then I try the smile design on the face of the patient. Then I send this type of picture with the rule to the technician that now has more information to start the workshop. Then the technician deliver me the workshop, and I started with the first mock-up. After the first mock-up, I had this problem, the second problem. So the teeth are inclined. Why the teeth are inclined? Because the central incisor follow with the facial bow, but in this case I have made an error because the facial bow follow with the papillary plane. But sometimes the eyes of the patient are not parallel with the plane of the horizon, but are inclined, like in this case. So always remember to choose the horizon plane, not the papillary plane, because the papillary plane sometimes could be inclined. And remember to take a picture with a facial bow with the patient seated on the chair. Then here you can see the horizon plane, and here you can see the papillary plane that is in the same of the horizon plane. The third problem that I've had was with centric relation. That was incorrect. So the centric relation on the articulator was different to the centric relation of the mouth of the patient. Maybe when I removed the wax from the mouth, it was too warm and not stable. So remember to put the wax in cold water and check it out another time in the mouth. And then, now that we've solved all problems, we can check the aesthetic appearance. And here you can see a lot of errors, a lot of aesthetic errors. In my opinion, one big problem is the communication with the dental lab, especially when I've worked without my favorite technician. In this type of extended case, my goal is a mock-up as much as possible similar to the final restoration. In general, the technician does not care the first workshop because it only works. And the technician likes the ceramic. The technician doesn't like the wax. So often the workshop is not accurate in shape and texture. So without a good workshop, we can't have a good mock-up. And this step is the most delicate of total rehabilitation. So I don't give the mirror to the patient if I'm not sure that the aesthetic is perfect. Now, with a good workshop, we can finally go on the final mock-up. And here we are. We take the picture, the same picture, but overall we need a shot with a natural smile of the patient to see the real smile line and how much he discovered the teeth and the gum during his smile. So during this step, I also tried the phonema S with 61, 62, 63, and the phonema F with 55. S is very useful to see the jaw motion of the patient. Some patients indeed have an horizontal jaw motion that could break the restoration and that could break the mock-up. The phonema S is also useful to check the vertical dimension of occlusion, because sometimes with the new vertical dimension of occlusion during the speaking, the teeth of different arches of the patient move in contact during the speaking, during the function. So we have to wait about 15 to 30 days, and then we check another time if there are a lot of posterior contact. Maybe you have to decrease the vertical dimension of occlusion. And the phonema F is very useful to evaluate the central incisor length and the overjet of the patient, so the posterior anterior position of the anterior teeth. Now we can stamp the mock-up, and yeah, you can see the spot etching, and you can see the Teflon. I use the Teflon before the mock-up because here, because with the Teflon, the papillas can draw into the mock-up. Because sometimes the mock-up have to stay in the mouth of the patient for 1 month, 2 months, or 3 months. So now we can stamp the mock-up, and here you can see different type of silicone guide, and the problem was that these different type of silicone guide are made by the same technician. My advice is to use this type of silicone guide. The silicone guide has to be very small but strong, because I asked the technician to cover the silicone guide with an hard S6 that has to cover the entire surface of the S6 to give more strong to the silicone guide. And this guide is very useful because it has a line between the central incisor that help me during the insertion of the guide itself. And I always use this type of material, Ivoclartelio, and I always use the A1 Telio. Why always I use the A1? Because this material is very strong, but is very translucent. So if the patient has A 3.5 teeth, for example, if you stamp with this type of material A1, the color, the new color of the patient will be white, but not too white. So the new smile of the patient is very better than the old one. And now you can see the real situation, my real situation. So the patient went to my office for the first visit, and I've taken 1 hour. Then I've taken, for the case studies, 1 hour and a half. Then I've stamped the first mock-up, 2 hours. But the mock-up was wrong. So second mock-up with correction of centric relation and facial bow, another 2 hours. Then we had the aesthetic problem, so I've asked another mock-up with the shape correction, and another 2 hours, 15 to 30 days. I've taken 2 hours for the mock-up because when I stamp the mock-up, I stamp one time the mock-up without spot etching to check the occlusion and to check the aesthetic. Then, if the mockup is good, I remove the first mockup, and in the same appointment with Teflon and spot etching, I stamp another mockup. And now move on this street. 6, the 5 appointment. I've taken 3 hours to the preparation of 6 mandibular teeth for buccal occlusal veneer. And you have to remember that after the preparation, I have to stamp the mockup. Then another 3 hours to the cementation and to place the crowns on implant. Then for 8 maxillary teeth, I've taken 4 hours, and another 4 hours for the cementation. And then I've taken 1 hour to final photo and to deliver the new Michigan bite. And this is these ones were my preparation after the stamping the mockup. So I stamp the mockup, and then I make the preparation. And
sorry, Edo.
Okay.
Edo, sorry, just a moment. I just want to say to everybody that if someone of you has some problem with the audio, please check the other channel with YouTube or Instagram. Sometimes it could be better on YouTube. Just this stuff because someone wrote to me. So let's go. Sorry.
Okay. Okay. Yes. Yeah, you can see my preparation. So I stamp it the mockup, and then I move on with the preparation. And here you can see the instruments that I love to use. The first one is the Oracle metal strip that I use to open the contact point when I need to open. Then I use the OptiDisc Care OptiDisc to polishing, and sometimes I love to use these particular tips of Soniflex, the 73 and 74, to finish this preparation. And here you can see the preparation. In this case, with strong abrasion, my final restoration are often additive. So I prepare over the mockup with standard thickness. Here you can see the standard thickness 0.2, 0.4 in the cervical area, 4 to 6 in the central area, and 0.8 to 1 millimeters in the incisal edge. And here you can see a very, very, very low, very light chamfer. And here you can see my preparation, and you can see the superficial natural texture of the teeth because my preparation is very, very soft. Now we move on through the cementation, and I've used the same steps of the previous case. And I've cemented a lithium disilicate buccal occlusal veneer in adhesive way, like the previous case, and I've used the high-load flow. And here you can see a clamp that I love because it's very small and is very useful when you want to cement two neighboring veneers. Then I always use this blade, the number 12, because work better than the scaler. So I work a lot before the polymerization, and then I use this type of blade. Here, very important point. When you etch the ceramic, for example, like in this case, the lithium disilicate, you have to know that on the surface of ceramic, the technician, to give a very polishing and finishing and smoothy surface, the technician put on the ceramic, the glazier, so a surface surface ceramic, feldspathic ceramic, and sometimes the glazier can move inside the ceramic. But the problem is that this area of glazier is very hard to etch. So if we see the glazier inner to the onlay, we have to remove the glazier with the sandblasting, and then we etch another time the ceramic.
Okay, just one thing, Edo. I'm sorry.
Yes.
In 5 minutes, we have to disconnect the histogram for the length of the direct, but we will start again. So I just want to say to the user to stay connected and wait. When we disconnect, after we will start again with a new direct. So move on.
Okay.
I will say to you.
Perfect.
Thank you.
Okay. Okay. Here you can see the zirconia ceramic crowns on the implant, and on the right side you can see the other lithium silicate verniers, and here you can see the posterior teeth that were monolithic zirconia crowns. And now we go on to cake maxillary impression. You can see my preparation that were very similar to mandibular preparation. Here I've used the polyether, Impragum of Trem. And here you can see the monolithic lithium disilicate. Okay, did you think that my error were finished? Here another error. Another one. When I've tried the 2.4 only, I've seen this problem. My preparation line was too buccal because I wanted to be minimally invasive, and I didn't open the mesial contact point. But sometimes, overall in aesthetic area, we have to prepare more that we want, like in this case. So I had to modify my preparation, and this one was the new preparation.
Just a moment. Sorry, Edo.
Okay.
We have to start again with the other direct on Instagram. I just want to take the time, just because we are here, to ask you something about the material. Someone asked us which material do you prefer, especially in relation with the antagonist. I think they mean depending on natural heat or something like that.
Okay. I think that the problem of the antagonist is not the material. I mean that if you use, for example, feldspathic or lithium disilicate or zirconia or composite, on the antagonist is the same. When is the same? If the surface is very smoothy. So if the surface of zirconia is very smoothy, is very finished, is very smoothy, we haven't the problem with the antagonist. So in general, if I can, I prefer the lithium disilicate, but I prefer the lithium disilicate because I can cement the lithium disilicate in adhesive way, but the zirconia is too hard to cement in adhesive way.
Okay. Perfect.
Okay.
Really clear.
Yeah.
Okay. Thank you. We start again on Instagram, so you can go on.
Okay. Thank you very much. Okay. So here you can see my new preparation over the mesial contact point, and here you can see the adaptation and the placement of the new onlay. The same step of the cementation. So I used the Evoclar 5% ceramic etching. Then I used the orthophosphoric to remove the to clear the surface. And do you remember the starting condition in which I've lost 2 implants? So I've lost this 1.6 and I've lost this 2.6. So yeah, so to solve the problem, I've decided to change the shape of 1.5 with an overlay, and I transform the 1.5 from premolar to molar, and then in 2.5 I change 2.5 crown on implant in 2.6, and that's it. The final situation. The comparison from the starting to the ending situation, the new face of the patient, and here you can see the new smile of the patients, the rehabilitation from different side. And here you can see that I've cemented my restoration over the free gingival.
For the admin to. Okay. Here we are again. Sorry, guys.
Okay. Can I move on?
Yeah, sure. You can go.
Okay. Okay. So here you can see the final situation, and here you can see that these are not a recession, but I've cemented my restoration over the free gingival margin because the smile line of the patient was medium. So I could stay totally on enamel with a supragingival preparation. And here you can see the occlusal view, where you can see the transformation from the second premolars in molars, and you can see the preparation over the free gingival margin on the right side, the picture on the right side. And here you can see the starting situation at the rest position and the rest position at the rest. The exposure of mandibular incisor is more than the exposure of maxillary incisor, but you have to remember that the patient is 75 years old. Okay, I finished it, and now I want to close my lecture with a message based on my big error that I've done in this case.
Okay.
Here, if you look closer, you can see the black space under contact point between central incisor. When I saw this problem, I immediately thought that was an error of my technician. But then I see the photo, and then I've discovered that it was my error during preparation, as you can see here. So my preparation were too coronal on medial size to have a good emergency profile. So my final message is to discuss every day our work and our abilities with the colleagues and also with the dental technician. Take a lot of photos and never stop learning. Here you can see my contacts. If you want, I suggest to you to see the Think Adhesive YouTube channel to see a lot of tips and tricks like this one about prosthodontic and restorative. Thank you so much for your attention, and that's it.
Thank you very much, Edo. I think it's a really outstanding presentation, and all the mistakes are really interesting to see, because everybody in our private practice have mistakes, but it's really important to show and to share with each other. I just want to ask you some more questions that arrived. They ask, how do you perform a differential diagnosis from parafunction to, I think they refers to the first case where the man used to drink a lot of lemon.
Okay.
And so how is the differential diagnosis, and how do you manage the material also in that case, the provisional crown for the long period. Are you scared to something? You use bite, something splint, or something like that?
Okay, so when I make the history of the patients, like in the previous case, I know that the patient was in deep bite, and I know that the patient used for a long period of time, about 20 years, a Michigan splint. So I know that the patient during the night of the patient, the teeth haven't contact. So I know that the problem wasn't the parafunction, because the patient was protected from the parafunction by the Michigan splint. So I had to looking for another cause of the problem, and in my opinion, the problem was the deep bite with the lemon intake. Then when I check for the first time the jaw motion of the patient, and when I check the situation of the patient, I've seen that the patient is very stable and is very relaxed. So I don't know if the situation wasn't clenching, but I know that the most important problem maybe is not the clenching. And when I work in these cases, at the end of the rehabilitation, I always use a Michigan splint. Sometimes, if I'm sure that the patient hasn't clenching, I use only an Essex, but in general, I prefer to use a Michigan splint, and I always use with this type of patient lithium disilicate, because sometimes we could have some aesthetic problem, but in general, this type of patient with great abrasion are all patients. So in our patient, we don't have the aesthetic problem. So I prefer to use the lithium disilicate.
Okay, perfect. So I think that's all. I just want to remember to everybody that the video, thanks to Edoardo, will stay on the YouTube channel, and you can see it again and again every time you want. Okay, here we are. And yes. Of course, Edoardo have give you the contact if you want to to write to him.
If you want to contact me, you can contact on my email on direct on Instagram. I work a lot on Instagram, so wherever you want.
Perfect. It was a real great pleasure for me to stay with you this hour, and I hope to see you soon. I want to say goodbye to everybody and to stay strong in this difficult period.
Very much. Yeah, thank you very much for your invitation. Thank you very much for your work. Thank you very much for the beautiful of the page. When you called me, I say yes, because I see a very high quality photo on your page, very high quality cases on your page. So thank you very much.
Thank you. Goodbye everybody. Ciao.
Bye bye.
Buona serata. Ciao a tutti.